Coming up on the Doctor's Hospital podcast.
Because there are so many different tissue types of ovarian cancer, there is no one standard test that can be performed to diagnose an ovarian cancer very early. And this is why most times it is considered the silent killer.
Doctor's Hospital Specialist Clinic is where trusted and best care meets consistency and dedication. Let our expert specialists take you on a healthcare journey where warmth, compassion, and your well-being come first. From diagnosis to prescription, we are with you every step of the way, ensuring your peace of mind. Visit us today at Centerville Medical Center, Collins Avenue and 6 Terrace, and discover quality, compassionate healthcare at Doctor's Hospital Specialist Clinic.
Welcome to the Doctor's Hospital podcast. I'm your host, Alexis Burrows, Marketing Director at Doctor's Hospital. Today, I am pleased to be joined by gynecologic oncologist Dr. Saida Bowe, who is a physician in the Doctor's Hospital space and is joining us today to talk about gynecologic cancers. So welcome to the podcast, Dr. Bowe. It's a pleasure to have you on.
Thank you very much for having me, Alexis.
So I know I don't have this on our list, but I do like to start, especially with a physician that I don't necessarily have a lot of engagement with. I do like to start to kind of get an idea of how you got to, the specific area of medicine that you're in. So can you just give us a quick backstory of why gynecology, and then a step further, why into the oncology space within gynecology? Because that's a lot of years of study.
I know. Yes, agreed. So why gynecology? Why gynecologic oncology specifically, right? Gynecology, so gynecology goes with obstetrics.
Mhm.
I fell in love with obstetrics, fell in love with gynecology because it gave me the ability to operate. It gave me the ability to speak to young women, speak to women about their health, taking charge of their bodies,
Mhm.
recognizing that there is something abnormal, knowing what are the warning signs that you should be concerned about, knowing when to seek medical help,
Mhm.
especially with our young ladies, encouraging them to be in charge of their bodies. So that I loved. Then obstetrics, while I don't have a complete dislike for it, sometimes can be not all that exciting. So a lot of my colleagues always laugh at me and say that I like the weird and wonderful, the
Mhm.
off the wall things in obstetrics. And yes, I still do. But gynecology, like I said, gives me surgery, which is very exciting for me. Why oncology? I sometimes feel that I didn't choose oncology. Oncology chose me,
Mhm.
right? It was not yes, this is what I'm going to do ultimately. I decided obstetrics and gynecology, but never oncology just because. But it chose me in that when I first came to Freeport while in my residency program, there was a lot of the oncology patients that I was assisting and managing and getting them fast tracked or making sure that they were being referred appropriately to Nassau so that they can start their treatments and have whatever surgeries that was necessary. Also, while in training in Nassau, I spent quite a bit of time with the oncology service. So was exposed to a lot of it during that time. And then, like they say, the rest is history. I went and did a fellowship in gynecological oncology. And, a lot of people have this view that, oh, it is very morbid, but I think patients want to know that they have somebody that is there, encouraging them, not hand holding, but giving them the real facts of what to expect and
Mhm.
encouraging them as they need to say, this is what it is, and having the frank discussions that a lot of times we don't want to have.
Right.
You see a patient and you know that there's nothing short of a miracle that is required at this point, then
Mm-hmm.
that's what sometimes it requires. And yes, those conversations are not the easiest, but I think it makes it much easier sometimes for the family and the patients to deal with.
Yeah. I mean, I think that's the thing, if you were indeed engaged and interested in the weird and wonderful, then oncology would be kind of a natural extension of what you would go into, right? And I realize I buried the lead a little bit. I do know that you operate primarily out of our Grand Bahama offices, correct? In Freeport
Yes.
Medical Center and Kavala Medical Center.
Yes.
Okay. All right. So just wanted to make sure I remind the folks of that. So, let's get
But I
into.
do,
Oh,
hold on.
go ahead.
Sorry,
Fill
just a
in the
quick pause.
blanks.
But I do offer a clinic on a Saturday once a month that we've just recently started as well.
In New Providence.
And that clinic, yes, is at the CMC.
Okay, awesome. There we go. Don't worry, we'll get all that in at the end as well, to remind our listeners. So let's get into it then. Can you start by explaining what gynecologic cancers are and what types are most common, especially in our environment? Because I know from having conversations with other physicians, I find that there's what's common in the world, and then it's what's common in our space. As dependent upon our racial makeup, just physical location, all of those sorts of things. So, what are some of the common ones that affect us in our part of the world, in our country?
Okay, so gynecologic cancers. Gynecologic cancers are cancers that affect the female reproductive tract. So those are your ovarian cancers, fallopian tube,
Mm-hmm.
uterine cancers, vaginal, vulva, and cervical cancer. Those are gynecologic cancers. Breast cancer, while yes, that is a part of the female anatomy, it's also a part of the male anatomy, so it does not fall under gynecologic cancers in the North American space.
Mm-hmm.
In European countries, gynecologic oncologists do treat breast cancer as well, but we don't in the Bahamas. What are the most common ones that we find in the Bahamas? So one year it may be uterine, the other year it may be cervical.
Mm-hmm.
So it kind of teeter-totters between those two,
Mm-hmm.
uterine and cervical cancer
Okay.
being our most common. Cervical is not fairly common in North America, and that's just because of access. And, even when patients do get diagnosed, it's usually not as advanced as what we see locally.
Mm. Okay. Any thoughts as to why that is, or it is just the access to care or the access to screening? What is the difference here?
So, one, a lot of patients, when, especially for cervical cancer, when you do talk to them, it is that they have not had a pap smear in years
Mm.
for whatever reason because of oh, it hurts, it's discomfort. And, we in Grand Bahama do screening campaign, Don't Fear the Smear, trying to encourage women to get their pap smears. Pap smears less than 5 minutes most times. So yes, there is a bit of a discomfort, but 5 minutes can save your life.
Mm-hmm. Okay. So what are some of the
So
key?
just
Oh,
getting that screening
right.
is
Got you.
very, very important.
Understood. So, what are some of the key risk factors then for gynecologic cancers? And I know obviously when we talk about things like breast cancer, there's all manner of like initial self screenings that they will encourage women to do. So how can women assess their own risk and start to notice either the risk factors or some of the early signs of potentially having something going on?
Okay, so we can break it down into modifiable risk factors and non-modifiable risk factors,
Okay.
right? And some of the non-modifiable risk factors for gynecologic cancers would be things such as your family history and your own personal genetics. So if you
Mm-hmm.
have a family history of breast or ovarian cancer, then that increases your risk of developing those later on in life. And yes, we do know that there is the BRCA or BRCA gene that
Mm-hmm.
is very much so common within the Bahamas. So if you have a relative that had any of those cancers or even pancreatic cancers, then they should have been tested for that genetic mutation so that you can then be assessed to see if you have the mutation and possibly go ahead and have some risk reducing surgery
Mm-hmm.
if it is appropriate. The other genetic mutation that, or the genetic cancer that can be found would be Lynch syndrome, and that is linked to uterine cancers and colon cancer. So again, if there is a family history of colon cancer,
Mm-hmm.
that should be screened for because persons may have, you may have an uncle and aunts that had colon cancer and they were diagnosed at a very early age. So then now the question is this as a result of Lynch syndrome? And if it is, then as a female, you do have that increased risk now of developing uterine cancer if it is from genetics. In terms of the modifiable risk factors, so obesity is a very big risk factor associated with cancers, particularly uterine cancer.
Mm-hmm.
And we know, again, we have a very high rate of obesity in our country. So this is why, as I said earlier, there's that teeter-totter between uterine and cervical cancer
Mm-hmm.
because of the obesity risk factor.
Right.
The other things would be things such as smoking, cigarette smoking, along with alcohol use. Those can also increase your risk of developing cancers later on in life.
Okay. So, what are some of the current recommendations for screening? Because, like I said, I know from, conversations across the medical space, no matter what it is you're talking about, screening tends to be a big part of the conversation because early detection is critical in most things. So, what are the current recommendations for screening and prevention of gynecologic cancers? And have there been any recent developments in this area in terms of advancements in how screening is done? Less invasive, anything along those lines. You talk about like the pap smear and things like that. So just kind of walk us through, the recommendations for screening and prevention and any recent developments in that area.
Thank you for that question. So, in terms of recent advancements, I'll start there first.
Sure.
For cervical cancer, we now have the HPV testing, and the HPV testing can be done even as a self test. It's just a swab that the female would do, send to the lab, and if it comes back that she has high risk HPV, then the provider would likely go on to perform a pap smear
Mm-hmm.
and determine if there's any abnormality on her pap smears. She may then be recommended to have a colposcopy depending on what the pap smear shows. But again, it now
It starts with that
decreases that
HPV.
discomfort that
Right.
patients have when they have to have a pap smear. So yes, that is something that is new and something that we are hoping to bring to the Bahamas very soon in terms of just being able to allow patients to do the HPV testing on its own. Currently, yes, we do the liquid-based pap smear along with reflex HPV testing, or we do co-testing depending on the provider. They would go ahead and do both the pap smear along with the HPV testing at the same time. Now, in terms of ovarian cancers, because there are so many different types of tissue types of ovarian cancer, there is no one standard test that can be performed
Hmm.
to diagnose an ovarian cancer very early. And this is why most times it is considered the silent killer because the symptoms that women will present with, a lot of times they are very vague symptoms.
Mm-hmm.
She may have feelings of fullness very early. She may have some constipation, bloating, and a lot of times physicians just would say, "Oh, that's just you have gas or abdominal pains, and let's just try this." And so that can sometimes take a while before it's diagnosed that this patient actually has an ovarian cancer. But now, if you have, family history, then definitely this should be something that should be investigated. And how do we investigate for ovarian cancers? With a pelvic ultrasound scan. But having a patient have a routine or pelvic ultrasounds every 6 months, every year is not warranted and not recommended
Okay.
by the international guidelines. For uterine cancer, most times we look at women that have abnormal uterine bleeding or postmenopausal bleeding. So a woman
Okay.
that has stopped having menstrual bleed for 1 year is considered to be postmenopausal. And any bleed after that is abnormal and should not occur. Once a woman bleeds after going through menopause, she should have an ultrasound done and have an endometrial biopsy to then go ahead and diagnose what is the cause for this postmenopausal bleeding.
Hmm.
And very commonly, it can be as a result of an endometrial cancer.
Right. And, I think it's interesting, like looking into our next question, wanting to know like what signs or symptoms, warning signs should women be vigilant about, and when should they seek medical attention? And I ask that, kind of knowing like, how do you know the difference? So let's say, for example, some people are um naturally, well, I'm saying naturally because my understanding of it, but some people naturally have um more intense menstrual cycles in terms of the amount of bleeding and things like that. Like how do you know when it's beyond what you've been accustomed to or what's normal? That you just say, "Hey, I have heavy periods." How do you know when it goes beyond that point? And then kind of thinking again around warning signs, symptoms that people should look out for to say, "Hey, I think I need to go and get checked out because this is just beyond what should be normal or custom."
Okay, so first thing that we encourage all women to do is whether it is your primary care provider, a gynecologist, every woman should have an annual well woman's visit,
Hmm.
right? That well woman's visit is your check in with your provider regarding a lot of things: your weight, your reproductive desires, your menstrual health. How are things going there, right?
Hmm.
Are you having heavy menstrual bleeding? Are you having prolonged bleeding?
Hmm.
Is it painful? So, are you having bleeding after intercourse? All of these are things that will be discussed at your annual visit and then investigated as needed. But if you are not doing your well woman's visit annually and then you see a provider, they may think that, okay, well, you're saying that you're having this, but maybe it's normal. And then you try something, whether it is that they put you on birth control pills
Hmm.
or something to an NSAID to try and stop and control the bleeding. Again, that's dependent on the provider, right? And your risk factors as well.
Right.
When you start these medications, there will normally be a follow up to see is the medication working.
Hmm.
If it is not working and they switch you and put you on something else, and that again is not working, then yes, there needs to be further testing to determine is there something more going on why this patient is not responding to these treatments that I have tried. So, yes, you definitely, I encourage develop that relationship with whether it's your primary care provider, a gynecologist, where you have your annual visits and these are the things that you talk about. And
Hmm.
if it is that you have to see them outside of one of those visits, then yes, please go in and see that person because that's not normal.
Right.
In
I
terms of, sorry, go on.
No, no, you go ahead.
In terms of cervix cancer, and a lot of the gynecologic cancers, unfortunately, sometimes there may not be any symptoms, right? The only one that
Mm,
usually has symptoms is that of uterine cancer, where there is either abnormal bleeding or postmenopausal bleeding. And so, cervical cancer, women for years can be asymptomatic. But again, if they are getting their pap smears regularly, then the abnormal cells that usually that will show up before the cancer, they would be seen, and you can have treatment for those abnormal cells to then prevent you from going on to developing cervical cancer.
okay. I know the point about the annual is a critical one. I know when we had the conversation with two of our primary care providers when we were talking about men's health in June, one of the things that they referenced is just the importance of that baseline of information, right? So your history, your ongoing history as a patient. Because your physician would then know what is actually normal for you. They would know what your baseline is. And as you engage with them, year to year and your annual, they'll be able to track, changes and adjustments. So obviously, you know, fluctuations in weight, changes in, the amount of pain during your cycle or the amount of bleeding during your cycle, the length of the cycle, all of these sorts of things, they would then have an awareness of and be able to say, okay, so we've gotten to a point where this is, beyond normal and we need to take it a step further. If there's an additional layer of screening that isn't just normally done in the annual. So I know that importance remains, that idea of having a primary care physician, whether, like I said, in the case of women, a lot of times it is going to be their gynae, but even if it's not, that you do have a regular rhythm of doing your annual, like you said, well woman's visit in order to make sure that the physician that you're seeing, one, you have a continuity of information, and two, you have an ongoing baseline of, okay, so this is where we are, this is where we were last year, this is where we were 3 years ago, and be able to track how things are changing to know if there's something to be concerned about.
Yes,
Yeah.
correct.
Okay, so, once it comes to a point where something is suspected, what is the diagnostic process typically involve? What does that look like?
So, depending on the cancer that is suspected, if it is something that is ovarian in nature, then normally we would go ahead and order imaging in the
Hmm.
form of an ultrasound and maybe a CT, chest, abdomen, and pelvis,
Hmm.
along with our tumor markers to see if those are elevated. Tumor markers can sometimes be normal, even in an early stage ovarian cancer, but you want somewhat of a baseline tumor marker before doing anything else more invasive.
Hmm.
For uterine cancers, again, the ultrasound, and then go ahead and do some sort of endometrial sampling, whether it's in the office or taking the patient to the OR for a minor procedure. Cervix, again, that may just entail going ahead, having a pap smear. If there is something that is visible at the time, then the provider would go ahead and do a biopsy and send that to pathology for confirmation. That comes back and says if there is cancer, then it takes you now down the imaging pathway with
Hmm.
a CT or a pelvic MRI, depending on which one is more readily available to you at the time.
Okay. All right. We're having a great conversation thus far. We're going to just pause for a few words from our sponsors, and we'll be right back on the Doctor's Hospital podcast.
Your health just got brighter with Lamp Insured. Sign up for Doctors Hospital's Lamp Insurance Supplement Plan and enjoy copay waivers and complete access with no upfront ER or inpatient collections. Only $30 per month. Visit doctorshosp.com/lamp to sign up or contact 242-822-1009. That's 242-822-1009. Your journey to affordable and worry-free healthcare begins now.
Welcome back to the Doctor's Hospital podcast. Again, today we are joined by Dr. Saida Bowe, a gynecologic oncologist, working out of both our Grand Bahama offices as well as a monthly clinic here in New Providence. And we are continuing our conversation. I did want to add something in here that wasn't originally on our list of questions. How much of a risk factor or how much role does it play? We have a lot of women who suffer through like endometriosis, fibroids, and other similar issues with regards to their reproductive system. How much of a role does that play? Like if someone has had, a history of issues with either fibroids or endometriosis, how much does that act as a risk factor for developing a gynecologic cancer?
Okay, so good question. I've been asked that many times before as well. Fibroids, there is not much of a risk of developing a gynecologic cancer from having uterine fibroids.
Hmm.
There are the sarcomas, the uterine sarcomas that can develop in an elderly person. So you see somebody that is in her 50s, 60s that is having an increasing size of her uterus that
Hmm.
almost appears to be that of a fibroid. That's not normal. That kind of signals and triggers that this may be a sarcoma,
Mm-hmm.
which is different from your fibroids. Okay, so it's not that the fibroid then goes ahead and changes to becoming this sarcoma. No. Now, in terms of endometriosis, there is that small risk of persons with the diagnosis of endometriosis developing a type of ovarian cancer.
Mm-hmm.
But again, it's a very small risk that
Okay.
is there in persons with endometriosis. So I'm not encouraging everybody that has a diagnosis of endometriosis to go out and have some major surgery or be very much so frantic that they are going to develop ovarian cancer. No, it is a very small risk. It's less than 5% of patients with endometriosis that would then go on and develop ovarian cancer as a result.
Okay. Fair enough. So we've talked about, warning signs, and the diagnostic process. So let's look at the other side of it. Um, once a diagnosis has been arrived at, what are some of the treatment options that are available, and how do you decide on the best course of treatment for a patient? So I asked that from knowing, even just from personal experience with my mom. She had breast cancer, and obviously, well, not obviously, but the way they approached it was, you would do chemo first, followed by surgery. And then you have some people who, depending on the nature of the circumstances, say, oh, well, we should do surgery first and then chemo. So, like, how do you decide on what treatment options are best and what order of operation you do treatment in when you're looking at the gynecologic cancer space?
Great. So the treatment options that your mother had, the neoadjuvant chemotherapy and then surgery,
Mm-hmm.
that there is usually offered in the ovarian cancer realm.
Mm-hmm.
So if it is that the female is seen and she has an advanced stage of her disease, we would go ahead and offer a few cycles of chemotherapy, reassess to make sure that the disease has responded, and then offer surgery. Reason being that you don't want to go ahead and give patients these major surgeries that would require sometimes a colostomy, which is where we would bring a loop of bowel up and they would have the bag that they would then now perform their bodily functions in, right?
Mm-hmm.
So that is, I know, something that a lot of Bahamians would not want to have happen. And so, because of that and the nature of the surgeries and how extensive they can be, if you perform an upfront surgery in a patient with an advanced ovarian cancer, normally we go ahead and give our patients neoadjuvant chemotherapy and reassess and then offer surgery. For uterine cancers, again, if it is that the disease is still early, even if it isn't, we go ahead, offer surgery, and depending on the stage, we would recommend adjuvant treatment, whether it is chemo only or chemo along with radiation treatment. And that would be depending on the stage of the disease. For cervix cancer, if it is still early, patients can be offered surgery, and based on their final pathology, they may require additional treatment, but it is always the hope that it is early and that additional treatment is not necessary. Now, if it is an advanced stage disease, meaning that the size of the disease is larger than we would offer surgery for, then
Mm-hmm.
those patients are recommended to have chemotherapy and radiation treatment as their treatment modality, and surgery is not recommended.
Okay. Yeah, I think from what I remember from going through that, was that a part of it as well is the idea of the chemotherapy is that it the intent is to eliminate as much of the cancer as possible, so that when you do, if you still have to go and do surgery, that when you do the surgical route, it's less likely for there to be spread during the surgical process. Is that correct?
Yes, and the surgery does not have to be as extensive.
Right.
So I'm sure in your, well, I shouldn't say I'm sure, likely in your mother's case, she may have not had to have as extensive of a surgery as if she had done the surgery upfront,
Mm-hmm. Okay, understood.
right? And the other thing also when we look at treatment is we have to take the whole patient into perspective, right? So if this is an elderly female that is somewhat bedridden and not doing a whole lot for herself, then we may just go ahead and offer some form of palliative treatment, whether it is in the form of hormonal treatment, giving just tablets for her to take, then that is also an option, And again, if it is a patient who has multiple comorbidities, she has hypertension, diabetes, she has congestive heart failure, and poor surgical candidate, then we would have to look at alternative means of treating, and surgery may not be an option.
Right. All right. So, diagnoses obviously come with a lot of impact for people, regardless of, the diagnosis, regardless of how extensive, there's still challenges that are raised to it. So how can a cancer diagnosis impact a woman's life beyond the physical aspects? And then, what support systems are available, as well as, what's the most beneficial way for people to find support if they do, end up in a situation where they're diagnosed with a gynecologic cancer?
Okay, so how does it impact it? A cancer diagnosis greatly impacts a patient's life. It impacts them psychologically, it impacts them spiritually, physically, emotionally, sexually, because a lot of women after this diagnosis no longer feel that they are a woman. They sometimes become sexually devoid and do not want to be intimate with their husband, partner any longer after such a diagnosis. Psychologically, a lot of them can develop depression, anxiety as a result of the diagnosis because there's always that fear, even if it is caught in an early stage, that this cancer will return. And any symptom that they have afterwards is usually considered like, hey, this is my cancer returning. So there is that fear element that they live with a lot of times for the rest of their lives, because they've now been diagnosed with cancer. Supports the major cancer societies, associations, all have somewhat of a support group for persons that are interested in joining. I know they are around. There are ones that are specific to women. There are those that are specific to the young adults and what they are dealing with in their cancer journey. Not all patients are willing to share that they have a cancer diagnosis and may
Hmm.
not want to be a part of such a large group to discuss these fears and concerns that they have. Also, there is support for the caretakers or partners for persons that have a cancer diagnosis, just to encourage those persons as to how to cope and manage now that their partner or their loved one has a cancer diagnosis. It does help. And, the Bahamas is a Christian nation, so I know a lot of church support groups are around. They're not specific to cancer diagnosis, but yes, there are persons that seek support from their churches at times.
Okay. Um, I guess in that same vein, support from the outside, but also, when people start to think about the way forward with a diagnosis, what type of questions should patients ask their physician, their oncologist, when they, come upon this diagnosis, to ensure that they understand, not just their condition but also their options for treatment and management?
So ask all the questions that you have. If you want to know, is there an alternative to the treatment that is being recommended? Is there, and depending on the stage, the provider may discuss with you maintenance treatment and what maintenance treatment looks like and how long you will be on maintenance treatment. What are there any clinical trials that are available that you may be a candidate for? Clinical trials may not be available locally within the Bahamas, but Bahamians are always traveling. So you can sometimes access clinical trials right there in Florida and receive treatments that way if it is something that you are desirous of. So just ask as many questions when you do get the cancer diagnosis. Understand what your options are and if there are alternatives to the option. And if you decide that you don't want to do treatment, which at times patients decide that they don't want to do anything, then what would that look like for you?
Yeah, sorry. The difficulty for me whenever we get to the conversation around support is just it's specifically to the timing of what happened with my mom. So my mom got her diagnosis within weeks of the country being shut down because of COVID.
Oh,
Um
Lord.
and so, people hadn't quite figured out yet. Obviously, this is just very early on. So this would have been
Mhm,
May of 2020. And so,
mhm.
you know, you go through the process of, the family isn't able to be physically together in the same way. A lot of the groups that did exist, it kind of took some time to figure out, how they would provide support in a non-contact space. And then, on top of that, it's just trying to navigate all of this now with the fear as a family. Well, if I get COVID and my mom now has a cancer diagnosis, you want to have that distance from a protective standpoint. So this part of the conversation for me is always a little bit difficult to navigate, because from my vantage point, the difficulty in trying to figure out how to provide my mom support during that time, to me, is ultimately the biggest challenge that we had in being able to manage through the process. And so, within a year and a half of her diagnosis, she was gone. Um, and I feel like if we could have found a way to get her support, um, in the midst of everything that was happening just at a national level and how much that impacted the ability to engage, the fear of, if, because obviously I'm at that point, I'm working in the hospital, my wife is working in the hospital. So in as much as, I'm not a physician, we were still in a lot of
You're still
spaces
exposed,
and you're
yes.
still exposed. And so, it was a very challenging time. And I think that's why it becomes such a difficult part of the conversation for me, because in as much as we knew support was critical, I think we had such difficulty in finding ways to provide and then to get her into a space where she could get support, that it's just like, for me, I recognize it retroactively that, you know that was a miss. And it's something that, if you could turn back the hands of time, you would have fought harder to figure it out in the moment. And so it's a difficult thing to discuss and to navigate in conversation, because you do kind of stop and consider that, right?
Agreed. But I guess the one thing to take home is that remember, COVID, yes, taught us how we're doing this now virtually, and we can do things virtually. Before
Mm-hmm.
COVID, very few meetings were held virtually. People jumped on a plane to have a meeting,
Yep.
right? And nobody thought that, oh, you're disrupting somebody else's life by insisting that everybody be in the same space to have a meeting.
You don't think twice about it.
And the support groups, they didn't recognize, obviously, because they're just support groups. They're not, physicians, and no fault of their own. They themselves had the fear of COVID. And so, yes, rightfully so, the country was on lockdown and all these things, and everybody was made to stay at home.
Mm-hmm.
And so, with all of that, it took them, I know, quite some time to then develop their own virtual space and how they were going to support persons with a new diagnosis and share information to these
Mm-hmm.
persons and what questions should you be asking and what treatments should you be considering.
Yeah.
So yes, I completely understand.
Yeah. So, I think it drives home the point of support, and how critical that
Hmm.
is. I think it's interesting too because when you have to consider personality differences as well, right? Not everyone is the go in a group and talk kind of person. Not
Yes.
everyone is comfortable typing in a WhatsApp group about their inner thoughts and feelings about a diagnosis like that. And I think unfortunately a lot of times we hear so many stories of people who you know don't overcome it or succumb to it, whether it's right away or eventually. And I think all of that kind of plays into it. So um you know I would say for anyone who is recently diagnosed, or has a family member that's recently diagnosed, a loved one, a friend, find ways to be supportive, but be mindful of people's personalities, their individuality, and try to do it in a way that is would be with in a way that they would receive it. Because um I think that's where there's a lot of times where we miss it, because we just say, oh, just go to the group, just join the WhatsApp group that such and such group has, or something along those lines, and not necessarily taking into consideration what do you as an individual person and your personality, your thoughts about the world, what does that look like for you, and what is best suited to provide you with support in the way that you would accept it,
Yeah.
because people are individuals.
Yes, we are. And some people, as you said, are not willing and are not ready to share when they first get into a group setting.
Hmm.
But again, they may find encouragement from just being there and listening to the other person share their stories
Hmm.
or what works for them, right?
Right.
So it has its advantages for those that are willing to then venture into that space and go.
Right. All right. So let's see if we can we can wrap up our conversation. Um
Sure, not a problem.
so I know we were talking about understanding conditions and options. So obviously we live in a space now where there's always a view to the future, right?
Mhm.
And so what are some of the latest advancements, whether it be in technology, whether it be in the pharmaceutical space, in surgical space, what are some of the advancements in the management and the treatment space that you're excited about as you look towards continuing to provide care for people in this way?
So, some of the advances that we've had recently would be things such as your immunotherapies, right? So, the immunotherapies, there are new advancements in the gynecologic space, and these are being offered as a part of adjuvant treatment along with maintenance treatment. So, trying to make sure that women have a longer disease free survival as possible. So, depending on the type of cancer that you have, your provider will talk to you and discuss what immunotherapy is available.
Hmm.
There's also different forms of targeted therapy that can be used. Patients with the BRCA gene,
Hmm.
there are the PARP inhibitors that are available to them if they have mutations, along with if it was an advanced stage disease. So this is a treatment that can be given to these women after they've completed their surgery, adjuvant treatment. Then they go on this for maintenance for 2 years. So it is allowing women to have longer, like I said, disease-free survival.
Hmm.
Yes, there's side effects associated with it, but again, taking a tablet every day and you can then look to being around for another 2, 3 years, possibly without having to worry about your cancer. I think it's a good thing. It's not that you won't have to see your provider every 3-4 months, but at least you're keeping your cancer cells at bay at this point.
Mm-hmm. It did remind me too, though, of one thing. And I don't know how it's different when it comes to the gynecologic cancers, but I know um there was testing in the breast cancer space. I know there's testing that you do to kind of determine um what treatment options are available. So like I remember with my mother, when they came back, she was triple negative, and so that meant that eliminated certain things from the space. Is there a similar sort of, and if you answered this already, forgive me, but is there sort of a similar line of pre-treatment testing to determine what treatment options are available for you in that space?
So I answered it, but not specifically to that. But
Okay,
we don't
sure.
offer in the gynecologic space pre-treatment currently.
Mm-hmm.
It is usually the post-surgical where
Mm-hmm.
the additional testing is done. So
Okay.
on a patient with ovarian cancer, then that specimen would be sent to check to see if they have the BRCA mutation.
Mm,
For endometrial cancers, we would look to see if there's any immune markers that are positive in these persons that can then allow them maintenance treatment with immunotherapy.
right.
So this is, yes, something that is offered to patients that they can then go
Right.
ahead and have this. And even these genetic testings that are available, again, like I said, they're very helpful because then if your cancer is a result of your genes, then it helps for you to be able to have that discussion with your family members, for
Mm-hmm.
them to go ahead and seek testing
Right.
on their own. And if they want to opt to have risk reducing surgery, whatever that may mean for them, then that is always a plus. Even encouraging them to make sure that they are getting screened so that should they be diagnosed, may potentially be diagnosed at an early stage.
Right. And it goes back to the earlier part of our conversation about, the benefits and the importance of early detection and getting screened and doing your annuals and things along those lines. It's very important to do that because finding it early, finding something like that as early as possible in the process gives you a much better fighting chance in the overall scheme of things.
Yes.
All right. So I want to thank you very much, Dr. Bowe, for joining us on the podcast today. It's been a very interesting and eventful conversation. I would like to remind our listeners that Dr. Bowe is available for clinic visits both in Grand Bahama and New Providence. We'll drop the information for our YouTube viewers. We'll drop it in the back end of the podcast so you can get all of the dates for July and potentially August. And thank you so much for taking time out of your busy schedule. Yes, we did this virtually. This is the first one that we've recorded virtually since we started back up with the podcast. And I think from a quality level, we're good. So thank you so much for taking time out of your busy schedule.
Thank you too for having me.
All
And my apologies for being emotional,
right.
but real men do
It's fine.
shed tears, right?
Yeah.
So,
All right.
yes.
So as always, to our listeners, we thank you for listening. We ask you to like, comment, subscribe, and share. And we will see you back here next week on the Doctor's Hospital podcast.
Let's face it, life is hard, but your healthcare doesn't have to be. Give yourself peace of mind with LAMP plans at Doctor's Hospital. Sign up today and enjoy the low-cost advantage. Get up to $5,000 in credit limit for non-covered services and 2 free nutritional consultations. Choose your plan today by visiting doctorshosp.com/LAMP. We make healthcare easy.